Welcome to the NEI podcast. In today's episode, we're coming to you from the 2024 NEI Synapse in Las Vegas, Nevada. We'll be hearing from one of our incredible speakers in this special extended Q&A episode to give you a chance to get your unanswered questions addressed from selected presentations.
Hello, my name is Dr. David Goodman, and I will be answering your questions from my presentation, Setting the Mood, Strategies for Diagnosing and Treating ADHD in the Context of Bipolar Disorder. The first question we received: with adult ADHD, is it true that if we are truly treating ADHD, then the stimulant doses will remain constant versus increasing higher doses? I would say that we don't want to make a diagnosis based on the response to medication. So for most ADHD individuals, you find a dose that's effective and they generally remain at that dose. This has to do with the issue of tachyphylaxis, or the development of tolerance where you need to continue to increase the dose over a period of time. This typically does not happen with adults with ADHD. However, if the cognitive demand and environmental demands increase, patients may complain that their ADHD medication isn't working as well, or that its effect is not lasting long enough. In that setting, you may choose to increase your ADHD medication during the time of high cognitive load, if that's something that's going to continue over a long period of time. However, the distinction has to be made between core cognitive symptoms and executive dysfunction. If the person's core ADHD symptoms are adequately treated at the current dose, and cognitive difficulties are arising because of an increased demand on a cognitive function, a higher dose of a stimulant or ADHD medication may not further improve their cognitive ability. You can certainly do that to see what happens, but if there is really no further improvement, then come back to the lower dose of the medication and institute organizational techniques and compensatory skills in order to address the increasing cognitive demand. Atomoxetine may be added to a stimulant medication, as well as viloxazine, with the potential improvement in executive function symptoms. But again, if you choose to do this, do it over the course of 2 months, evaluate whether there's any further benefit. And then if there has not been, then make it simple and eliminate the non-stimulant medication from the prescription. In patients with substance use disorder, primarily amphetamine use disorder, and the patient tells you when they use meth they feel calm and normal, I suspect ADHD, but how long do you wait for them to be clean before you'll treat their underlying ADHD? The fact that they feel normal and calm on methamphetamine doesn't necessarily confirm the diagnosis of ADHD, and I would caution you about that. The diagnosis of ADHD is predicated in childhood and adolescent symptoms, with a trajectory of those symptoms that are chronic, pervasive, and impairing over the course of time. ADHD symptoms will then exist in childhood and adolescence, which will predate their substance use, and particularly amphetamine use disorder. If cognition worsens during their time they're using methamphetamine, then methamphetamine is contributing to a higher cognitive deficit. So perhaps they should be clean off of the methamphetamine in order to get the baseline ADHD symptoms. In this regard, I would probably suggest at least a month of recovery, participation in an active recovery program before you considered using ADHD medication. And when considering ADHD medication, I might start with a non-stimulant, first to see if it's helpful, but also to see if the patient is interested in treatment or an alternative way of drug seeking by getting a prescription amphetamine medication. What are your thoughts on the Winder, Utah childhood ADHD symptom screener for adults with ADHD and other non-adult ADHD rating scales, the version 1.1. Is the ASRS better for symptomatic assessment after diagnosis? The ASRS, the Adult Self-Report ADHD Scale that patients fill out, it's the 18 symptoms out of the DSM-5. Each symptom is scored on a frequency basis of 0 to 4, and then by symptom count threshold, if they have 5 or more of 9 in the inattention or hyperactive impulsive categories, they fulfill symptom threshold. Now, the other criteria for ADHD is levels of impairment. So you need both symptom count thresholds and levels of impairment in several domains in order to make the diagnosis. The Winder, Utah Childhood Rating Scale, in addition to all of the other childhood rating scales, have not been tested and validated in adult populations to any great extent. That's the benefit of the Adult Self-Report Scales, which has extensive research and documentation on sensitivity, specificity, negative predictive value, positive predictive value. So this is the one that's routinely recommended. I will use it at baseline in order to assess baseline symptoms, and then periodically have the patient fill it out during treatment to see how the target symptoms have changed in frequency. And when you do that, also ask, with the decline in these symptoms, what improvement have you noticed in your functioning over the day? Again, documenting both symptoms as well as daily functionality is important. So I would shy away from childhood ADHD rating screeners because they haven't been validated in adults, in addition to the fact the descriptive language in the childhood symptom screeners and checklists are written for children. The Adult Self-Report Scale is reworded so it's more applicable to adults. They're more likely to fill it out accurately. How important is the history of childhood symptoms of ADHD in adults with ADHD and comorbidity of bipolar disorder? This is an interesting question. When you assess somebody who comes into your office at 22 years old, they've had 2 depressive episodes, and they have a history of ADHD symptoms since age 10, this is no longer a binary decision of you have ADHD or you have bipolar disorder, but you actually have both. So here the diagnosis of ADHD is based on the trajectory of cognitive symptoms, impulsivity, hyperactivity, emotional dysregulation since childhood and early adolescence. The specific episodes of major depression, which is usually the index episode for bipolar disorder, ages 15 to 22, would that indicate a concomitant bipolar disorder. Now, what's also important here is that bipolar disorder has its own set of cognitive symptoms, and so you need to clearly categorize the cognitive symptoms associated with ADHD and the cognitive symptoms that may be associated with the bipolar disorder. But generally, if you resolve the acute bipolar episode, the remaining cognitive symptoms will likely be a function of ongoing untreated ADHD. Do you have a good resource to improve documentation of ADHD visits in general, as well as how to document the use of stimulants in patients who have a history of stimulant use disorder and or bipolar disorder? So 2 separate questions here. One is there's going to be greater vigilance over documentation with patients who have a history of substance use disorder than for bipolar disorder. In regards to documentation of ADHD visits, I record and document what their mood is and their emotional tone. Are they reactive? Are they irritable? Are they short-fused? I document sleep and appetite changes. Do you have difficulty falling asleep or waking up frequently at night? Is your appetite suppressed? Are you losing weight? Other elements have to do with focus, concentration, and forgetfulness in the course of their daily activities. The next would be documentation of other people noticing this. Do you get feedback from your spouse, your partner, your coworker, your boss about inconsistency, tardiness, forgetfulness, and careless errors. If the patient is getting feedback about cognitive symptoms and impairments, then you can be assured that these symptoms are substantial enough that the environment recognizes it and works to accommodate the patient in order to help them participate productively. When it comes to substance use disorders and ADHD, you want to document either this is a history of substance use disorders, what their substances were that they were abusing, and how long ago this was occurring. The patient who has a history of substance abuse in their adolescence and 20s now shows up in your office at 45 and hasn't been involved with that for 10 years. Yes, it's a consideration, but it probably wouldn't affect the way in which I approach the ADHD. If, however, the person is clearly misusing alcohol, marijuana, narcotics, or other medications, then the question is, how can you recruit them to go into substance use disorder treatment concomitant with your ongoing assessment? Also, substance use disorders that are active introduce additional cognitive deficits. So you're not going to be sure whether the cognitive deficits you're assessing are a function of the SUD or a function of the ADHD, which is another reason why these persons should be in a recovery program and abstinent in order to have the dust settle and see which of the cognitive symptoms that persist are an outgrowth of the ADHD. So for this, it really is a matter of clinical anxiety, that is, the anxiety of the clinician, as to how far the patient needs to be along in their substance use disorder recovery in order to feel safe. For someone like this, though, non-stimulant medication would be considered first in order to see what the response was, but also to see whether the patient is cooperative or resistant. If they're resistant to using a non-stimulant, that may be indicating their desire to get a prescription stimulant medication that they can misuse. And for these folks, I would start, if you move to a stimulant medication, with long-acting, less abusable medications whose mechanized delivery system is less manipulatable in order to extract immediate release. These folks are vulnerable to misusing immediate release, and so it's probably recommended that you not use immediate release in these folks who are, again, actively involved in substance use disorder. The other element to this is if they are involved in active substance use disorder and they are abstinent from their substance use disorder, you may want to consider treating their ADHD sooner than later. For this reason, there is one study looking at substance use disorder and ADHD treated with methylphenidate, and it found that the relapse rate in substance use at 90 days was 5% versus those whose ADHD was not treated with a relapse rate at 90 days of 35%. So you may want to consider treating the ADHD sooner than later in a substance use disorder recovery treatment program. Is Vyvanse an option for people with bipolar disorder, ADHD, and binge eating disorder? The answer to this is certainly yes. If the bipolar disorder is stable and the patient is euthymic but continues to have core ADHD symptoms and binge eating disorder, Vyvanse would be a good choice, in large part because Vyvanse, lisdexamfetamine, is FDA approved for the treatment of ADHD in adults as well as treating binge eating disorder. Can you speak about Sunosi or medication for sleep apnea in the setting of bipolar disorder and ADHD? So let me focus on Sunosi and other sleep apnea medications. I was a principal investigator in the adult ADHD trial looking at modafinil that ran doses up to 525 milligrams, and the study was negative. So it never got an indication for ADHD in adults. For children, the modafinil study was positive, but there was a safety issue of a rash that was misconstrued as Stevens-Johnson, and they were asked to do a safety protocol over the course of a year. Given the expense of that protocol, the company decided not to pursue that. In regards to Sunosi, there is now a very good randomized controlled trial that shows a substantial effect size for Sunosi in adults with ADHD, although its use would be considered off-label, and we can follow this research to see whether the company is going to submit it to the FDA for a formal indication. Often I find that these medications won't be approved by an insurance company for ADHD. However, if the patient has ADHD and sleep apnea, this is how you might prescribe it to see whether there would be a benefit. You would be prescribing to somebody who had difficulty with tolerating other ADHD medications, the stimulant medications, the non-stimulant medications, or you might prescribe it first for sleep apnea in the presence of ADHD in order to see what cognitive symptoms improved with the amelioration of sleep apnea symptoms during the day. In regards to bipolar disorder, I don't know of any research looking at sleep apnea medications in bipolar disorder specifically, or bipolar disorder in ADHD patients as well. I suppose one has to be concerned about the provocation of hypomania or mania, but this research is very sparse to provide any clinical guidance. How would you treat a young male patient that did have stimulant-induced mania on lower doses of stimulants? Do you have a preference on the combination of a specific mood stabilizer and stimulant that you see works well in this case? So let me answer the latter part of the question. I don't find a particular combination works better than other combinations. For patients with bipolar disorder, you're going to use a mood stabilizer that you're familiar with, for which the patient will respond. You may start with lithium, you may start with a second-generation antipsychotic, you may start with a anticonvulsive medication. Whatever you start with, you're going to figure out whether it works. Once the patient is stable, mood-wise, then you can come in and add a ADHD medication. If you think adding a non-stimulant medication reduces the risks of mania provocation, the research wouldn't support that. So you decide whether you can use a non-stimulant or a stimulant medication, and then dose it accordingly for the ADHD symptoms and track out the mood symptoms. If the patient grows increasingly irritable, perhaps change. And if you changed in regards to stimulants, for that I would change compound. So if they had a provocation on an amphetamine, I'd move to a methylphenidate, or vice versa. In regards to the stimulant-induced mania, this might indicate a bipolar diathesis that has yet to be revealed, and you would go more gingerly when adding stimulant medication to your mood stabilizer. Also look for family psychiatric history. If the parent had ADHD, then you're on solid ground for an ADHD diagnosis. If the parent had bipolar disorder, the patient has ADHD, be mindful that they may have a bipolar diathesis that has yet to be revealed and may have been provoked by low-dose stimulant medication. All of this can be sorted out then as you monitor symptoms over a period of time with the changes in medication. Is there any benefit in giving bipolar patients with concurrent ADHD an extended release formulation of stimulants versus the immediate release? My preference is to start with extended release so that you don't have sharp ascension of PK curves or sharp descension of PK curves. Using the long-acting preparations, you get a smoother upslope and a smoother downslope so that it's less likely to be provocative for mood symptoms. That may be an outgrowth of the ascent and descent rates of the stimulant medication and not provocation of the bipolar disorder. Is atomoxetine less risky option when treating ADHD individuals and a bipolar patient? So the answer to that, I would say, is no. Atomoxetine has recorded cases of provoked hypomania and mania. Viloxazine is newer and doesn't have that documentation. However, I would make the presumption at this point, in the absence of research data, that viloxazine has the same risk as atomoxetine. So you're not necessarily reducing the risk of bipolar destabilization by using a non-stimulant, and my preference in these cases is to just go to a long-acting stimulant medication. If the patient has ADHD, bipolar disorder, and an active substance use disorder, then I would consider non-stimulant medications. What are your thoughts on promoting routine medication holidays for adults? So the basis of medication holidays evolved of children. It was thought that appetite and height were a function of stimulant exposure. And so those children who weren't eating well during the week, if you took them off the stimulant on the weekend, they would catch up with their appetite. If you took patients off stimulant medications on the weekends and the summer, you reduced the total annual exposure to stimulant medication, and that then reduced the risk of height suppression. However, if you look at the literature, height suppression is minimal at about 1/2 inch, and height catches up with the ADHD individuals in adolescence. So you have to measure the benefit of the medication in regards to academic and social benefits versus some of these risk factors that are fairly minimal to inconsequential. So I do not recommend holidays. Having said that, I have patients who will stop it on Sunday because they report a stronger effect on Monday, and that may have to do with some microtachyphylaxis that develops, and so eliminating it on Sunday and then taking it on Monday may actually reset the neuronal network, and you get a little bit more of an effect. But I wouldn't consider that a holiday. I'd simply consider that a single day missed dose. How do you explain THC and CBD effects on medications effectiveness for ADHD and bipolar disorder? Let's focus on THC and CBD for ADHD. Depending on the volume and frequency of the use of these medications, you have to determine to what degree these two medications are causing, and I call them medications because they're acting on the brain. So you have to determine the effect of these medications on soft cognitive symptoms. Will the use of THC and CBD every single day have an effect on the effectiveness of ADHD medication? I don't know of any research that would indicate that. However, it seems like common sense that if you're using THC, smoking marijuana, that will have an effect on motivation and cognition and will diminish the ability of ADHD medications to address ADHD. For bipolar patients, the consideration for THC is also with mood stabilization, and I'm not familiar enough with this literature to be able to give you a good clinical interpretation, except it's the degree. So if I have patients who are using THC or marijuana 3 times a week, I'm not bent out of shape or terribly concerned. But if they're smoking and using THC every day, 1, 2, 3 times a day, and they have been for months, now I'm concerned about its effect both on the effectiveness of any medication I use, both for bipolar disorder and ADHD, as well as the soft cognitive symptoms that would compound my ability to assess ADHD symptoms. What are your suggestions for treatment options due to the difficulty of getting stimulants right now? This is a bugaboo for clinicians across the United States. It is geographically variable and also pharmacy variable. So if you're in New York City, you may not be able to get the medication. If you're in Tulsa, Oklahoma, you may be able to get the medication. If you go to the Walgreens down the street, you may not be able to get the medicine. If you go to the CVS a half a mile away, you may be able to get to the medicine. It's led to a lot of frustration on the part of patients, families, prescribers, and pharmacists who interact with patients who, while off their medication, grow increasingly frustrated, impatient, and potentially eruptive. Suggestions include, if a patient is on Adderall, 40 milligrams and they don't have 20s, then you write it as a 15 and a 25. I know there's 2 copays. If they are on a particular compound, amphetamine or methylphenidate, try to stay within that compound and move to a different delivery system. However, you may find that you can't get a preparation in the compound and you have to move to the alternative compound as well. The other limitation to this are insurance companies that have formularies, and so you may be able to find a medication preparation within the compound you were prescribing, but because it's not on the formula, you have to go through a prior authorization, it'll be denied, then you have to go through an appeal process, and this becomes an administrative headache. Some companies have now allowed branded products during this period of time with the shortage, but there's no easy answers here. Some people have tried to move to non-stimulants in these patients. Maybe that will work. I've tried to move to preparations that are widely available because they're branded. So transdermal patches, both for methylphenidate and amphetamine, exist, and they're generally available. The other is hospital pharmacies tend to be better stocked or have better inventories than local pharmacies. Mom and pop pharmacies may also be more attentive to specific patient needs. If a pharmacy can anticipate the need, they can lock it into their inventory request, and perhaps that works out well. But there aren't any easy answers that I can give you, probably none that you haven't already thought of. Thank you all for your questions. It shows that you're attentive to improving your clinical skills and improving the lives of your patients. Unfortunately, we are out of time, and I thank you for your mission of improving your skills and helping patients understand their illness. Good luck.
Thank you for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit NEIglobal.com.